Abe Sutton here from the government. I'm here to help.
We always love to hear that.
CMS, folks we're familiar with. CMMI, I'll start there. CMS, obviously across Medicare, Medicaid, CHIP, the exchanges, we're looking around a $2 trillion annual program. Billion would be very different. The Innovation Center is really the R&D arm for CMS. So what does it mean to have an R&D arm? We're not clinical researchers working with cutting edge technologies. That's not what we do. We do payment innovation. What would it look like if we changed the incentives for the market? How would people respond? What would that change in the world around us? And so my job and the job of the center that I lead is to think through and run those experiments and say, all right, well, in this portion of the country, we'll run this test. Or we'll open it up and folks who want to come in voluntarily to say, oh, I'll participate in that program, and we'll see the impact that it has. And we respond to what we see in the market. And so we look at, for example, different provider groups and specialties. And we'll say, well, what if it looked like if we paid slightly differently for how nephrologists deliver care for patients with advanced stages of kidney disease or on dialysis? What would it look like if there was an extra bonus for moving a higher percentage of your panel to home dialysis? Well, it turns out patients are moved to the home in that setting. Nephrologists respond to that incentive. So we have data now that says that because we ran a model for a 5-year period and have that information. We take the findings of these models to reform how Medicare and Medicaid will pay for healthcare. And there's a couple of things that are really cool in this process. If we prove that one of our models is effective, defined at improving quality without increasing cost, or alternatively, decreasing costs without harming quality, we go through what we call a certification process where we say, hey, Congress, this really works. And Congress doesn't have to do anything. We just leave them a little notice. And we said, we're just going to do this for now on in Medicare and Medicaid across the entire country. So that's pretty cool because normally getting Congress to agree on things, pass a law is a whole process. And our job is to sidestep that process and say, if there are things that will be more efficient, if there are things that could get at the heart of how we approach things in healthcare, let's design the experiment grounded in data and approach it. And so we're a 406-person team at the moment. We've got 92 vacancies. We could circle back to that and why you should all come and join us. And we're working to design these payment models. That's what we do.
Yeah, no, it's a great start. And in fact, what I love talking about and having visited CMS in Baltimore at the CMMI office, what's really cool is it's very rare to be sitting in conversations where you just get to talk about the payment models and innovation around those models, because there is no, even as an engineer, there is nothing that I can do that can have the same impact as a line of regulatory change that Abe and team could do that would really create the influence and the impact at large scale in the market. So when we say the government is innovating, that's not an oxymoron in this case. It is actually the only way that many of the technologies that we're talking about today are actually going to make their way into real practice, because otherwise physicians and others won't use it.
This is coming off as fighting words.
Yeah.
In my marriage, my wife is the engineer, and the value of a line of code versus a line of reg text is something fiercely debated.
Absolutely. Except now in the world of AI, one has much less value now. As a coder myself, one has much less value. And in this particular case, what's really cool is that as I've spent time there, they're really legitimately looking for ideas. But often, and I just love to get your, just on a side note, comment like this is, you probably have people coming to you all the time saying, why don't you guys try this? And why don't you try this? And why don't you try this? And of course, a lot of the answers are because there is regulatory. But more importantly, you're looking for evidence. Talk about that a little bit and say what's easy about that and what's hard about that, so that when people do come to you with ideas, you can say, hey, if you have any ideas where there's already a bunch of data sitting somewhere and it can demonstrate X, Y, Z, there's more you can do. But a little bit of challenge about your organization around evidence would be great.
So we have a few shots on goal a year. And so we try and be driven based off the data. Do we have a reason to believe that this can work? All right, so let's take a step back and think through what that could look like. Maybe somebody has done an intervention with some population to say, it turns out if I give them a text reminder after a visit, people are more likely to go and fill that script, or they're more likely to come in for the next visit. Okay, what was the population? Oh, that was done with a commercial health insurance population who were all enrolled in this insurance through their employer. We're doing it off of. All right, well, how will that translate to the Medicaid population that we intend to do this intervention with? That's something we think through, but we look at evidence where it works, and then we'll do limited tests to try and get the data to see if it works with the population we're responsible for, which is, for my center, Medicare, Medicaid, and CHIP. And so we try and just be driven by the evidence. We get ideas, and it's really helpful to get those ideas from people coming in and giving us, hey, here's how we think about it, or here's what our technology has done in this setting. We ran this pilot. Seems to be a favorite word used a lot. We ran this pilot with this payer, and it really works. So you should just open this nationwide and do it. And it's helpful to understand and dig into the data on it. Right. So changing the diet and nutrition supplements available to that population. It was a Medicaid population. That local Arizona Medicaid plan paid for it. That's helpful. What was the eligibility criteria? Oh, it was people who had these cardiometabolic issues. And what was the intervention? What did you pay for? What time period? Oh, 6 months. But it was done for a 3-month period. It really didn't have any impact. Like, we really go in depth and we'll interrogate everything. We also, at this point, have loaded up all of the evidence on all of the 60 plus experiments that we've done, what has worked and what has not, and the pitches we receive into a bit of a database. And so we actually do use AI to help design our models now, and definitely for our evaluation strategy. We now have 60 models where each of them has somewhere between 3 and 7 years of data from how it worked. And we took that information and said, here's the raw data that was received. Here's the output of how we summarize the evaluation reports from it based off this. And this new raw data for this new model, what should the first draft of the evaluation report look like? It's not perfect, but it actually has been quite helpful and helped us to launch 9 models last year.
Is any of that available? Is any of the database itself available publicly, or only the results?
We put out the results in PDFs, and so you could access the PDFs with the evaluation reports that have the data that is publicly disclosed on them. But you could access all of them, load them up to something, and recreate the exact same thing.
Great. And so now, having set that stage, the Access program, I think ACCESS, it's an acronym, right? It's not.
Advancing chronic care with effective, scalable solutions.
There you go. So Access. So you can look that up. You can Google that. So let's talk about the Access program. And what's neat about it is that it's not a program in which you're saying, we're going to go try something. You're saying, here's what's already worked. Now, who's with us and who's going to go implement it? So if I captured that correctly, that's great. If not, elaborate and say, what would you want their hospitals, health systems, members here? How could they participate, and what would you love to see them do?
We're at a moment where there is a tremendous potential in these different generative AI models. We all see it, but what are the applications that they're having in the healthcare system today? First and foremost, we see an administrative application, which is valuable. There's no barriers from regulation to doing that, and people should engage and do that. We want that to happen. Unfortunately, a lot of what is driving our current utilization trend is enhanced performance on revenue cycle management, ambient scribes capturing more, which has led to actually relatively stable revenue outlook for the healthcare system today, right now. Hospital systems are doing well. HCA just reported. We all saw the profitability there. Okay, but what are the other things that can be done with this technology? There are digital therapeutics out there that are serving cash pay patients, going in and just, hey, I'll download that app. It'll help with my mental sanity and the load, help me manage a chronic condition that I have. There are people who distribute via the employer base or via commercial insurance plans directly and have things available for free to beneficiaries. In Medicare, we don't tend to have those things available because we don't pay for it. And so there's a question of, do we think there's value in these applications? Seemingly there is. There are people who are driving results there. There are people who are willing to pay for it in other settings. So what would it look like if we suddenly expanded access to the Medicare population, or maybe in time the Medicaid population if a state jumped on it, or private Medicare Advantage plans? That's what Access is meant to be an answer for. It's not locking in on any one technology. It has broad tracks. We have 4 of them: an early cardio-kidney metabolic health track, a later cardio-kidney metabolic health track, an MSK track, and one focused on behavioral health. And we say in these 4 tracks, which cover around 70% of Medicare patients between them, is we're going to track an outcome in these tracks. And if you could achieve the outcomes that the track has, you'll get the aligned payment for achieving it. So go in, engage the beneficiary, customer acquisition costs, keep them engaged in. We'll pay you a monthly amount. And as you achieve the target goal, we'll let you receive the full payment amount. No big sales cycle into a system, no big sales cycle into a plan. Totally different go-to-market. It's the go-to-market of a direct-to-consumer play, but suddenly we have the entire original Medicare book of business, and we're hoping to bring Medicare Advantage plans on board for a similar approach at play here. So you could massively scale and have venture-backed businesses that are doing these things, but the catch is you have to engage people and achieve the outcomes. And working with healthcare systems might be a good distribution network for it. Health systems can launch their own plays, though I'll note that the actually most effective way for a health system to really capture more than a typical access participant is in value-based care, is in things like our new long-term enhanced ACO design model, where we say, take on global total cost of care risk for the next decade. We will give you a stable benchmark without rebasing, without resetting that amount for 10 years, and go in and apply new technologies to enhance your workforce, lower the spend you need to have to produce the same result, and capture that. So there's a pitch that you can make to the CFO in the system of this is the moment to go in on these investments because we can capture that in the next decade via this model.
So when you look at the folks that you're speaking to, what's surprising you about those that are showing more interest versus what you thought you would see when you were first thinking about the Access program?
So Access was first announced in December. We put out the applications to join Access in January after the announcement. There was on a month lag, and we're a few weeks out from releasing what the payment rates will be there. Applications have started to come in. There's broad interest. People like the idea that it's a streamlined go-to-market. They like the idea that it's scalable. There are questions on will it work with their model. One thing that is hard for folks to wrap their heads around is we're not as prescriptive as a typical government program would be here, because we're not trying to lock in on any one technical intervention. For all we know, a year and a half from now, the standard is and what is capable, what these things can do will look totally different. And so the way you'll intervene will look different because the cost of what you could support in doing this will look different. We went through in our minds and looked through what's a typical CAC, what's a typical data cost monthly for using one of these with the engagement rates that we think are necessary based on what we've seen in some of the applications in the commercial marketplace, and what's a reasonable cost that someone who's spending, some margin on that, and we set up a payment rate. But everyone's going to develop different things, and people who could have a lower cost profile while producing great results will be sitting on something that can be quite profitable in time.
Yeah, and remember, I'll open the question up in about 4 questions in about 5 minutes, and ask tough questions because there's a brand new program, there is innovation, and the best innovation is that which is going to allow you to install it and actually use it in your environment. So where do you feel like you've heard from either senior health system C-suite officials where they might be questioning it or they're not quite sure how it would work? What have been the major, if not objections, but at least confusion areas that you might want to clear up?
Folks have definitely had questions on the payment rates. Folks are excited, though. I think people see this as a way that they might, this access and really lead as well, more from the system perspective, is that they might be able to adopt and apply these in clinical delivery without undermining the revenue that they depend on, in a way that if you just stop doing these fee-for-service visits that are no longer necessary, if you employ this intervention correctly, you'd really undermine your business model. And no one's in a situation to do that. So if we move in a direction where you can deploy this and still succeed, that will set people up for success. And so there's questions around, have you considered a COPD track? COPD startups have come in to ask us, why not COPD? I mean, people have asked us in the Medicaid space, have you considered one on maternal health in the Medicaid space, or one on childhood conditions or behavioral health in children? Medicare is easier for us to work in just from a regulatory process. In Medicaid, we have more limited authority in our center. We do have some, and then states have to opt in to do it. And so we were able to move quickly and set this up in Medicare and are now turning to engagement with states. We did clarify for states that in lieu of services, any access type program they set up on the state level and their Medicaid program would count as in lieu of services. So we're able to give that clarity.
Can you say that again? Because that's actually pretty interesting, is that at the state level, then if they do a twin program, what would that look like?
Meaning if they take our tracks or set up more Medicaid-oriented ones for different conditions, and they set up the similar outcome-aligned payment structure, same criteria, it would allow it to count as in lieu of services, which means that they'd get to basically have it in lieu of other Medicaid spend. And so there's structural benefits from the state perspectives and how they draw down their match funds that make that a reasonable thing for them.
Oh man, so actually that's kind of like if there are federally qualified healthcare centers here, so FQHCs have always been at a disadvantage because they have not been able to invest in these things. But if it's possible, this is one area where FQHC senior executives should think about this, because obviously they're getting funding mainly from state as opposed to federal. But if you do these matching programs, you don't have to do any thinking now. You can actually just implement and get the services in lieu. I think that's a fantastic program. Have any FQHCs talked to you or reached out to you about thinking about this?
Heard from FQs on this one, largely because states would need to take that option. And then if the states take that option, it would obviously impact a lot of providers who impact the Medicaid population in particular.
Yeah.
So we'll have to see how that plays out.
Yeah. So this would have to be like a super innovative FQHC. So not necessarily everybody would be able to understand the complexity of this. But what I wanted to also do is kind of like, can you tie in the fact that this is so evidence driven already? You're going backwards and understanding what has already been successful so that you try this out. So it's not really one of those experimental kind of things. The experiment is, can we implement at scale, right? This is a scalable thing. But you've also been working with the FDA on the Tempo program. How many of you have heard of the Tempo program? Just a few of you. All right, good. So if you can describe the Tempo program and how it aligns with access, and how can somebody with medical devices, for example, connect with both?
You're the winner. You're tracking it the closest. On the same day that we announced the access model, the FDA came out with an announcement of Tempo. And this was a coordinated move. As we were thinking through what it would look like to have reimbursement in this space, the FDA was thinking through, well, how do we ensure that we're actually able to get usable data from that and draw real conclusions on what it would look like? Not for the limited world where fewer people have been approved to be in the market, but for the world where it's flooded because everyone's coming in. And they decided, you know what, we're going to set up a pilot program of our own, which we do tons of models in the Innovation Center. That's all I do, is I get to spend time getting ideas and thinking of people and discussing interesting models. It's a fun gig. The FDA obviously is running massive programs, but they said, what if we just gave market access, accelerated pathways there, and then went and reviewed things later for 40 digital therapeutics. Let's let folks come in and access the access model. And so if you're applying to access, the FDA is going to let you apply to be in Tempo. And we'll be having a pretty open selection. We'll let everyone in. As long as you meet these criteria, you could try and do it. We will then take all the data on who performs best and post it publicly. So who performs best in each category, the outcomes they achieve, it'll all be there. So everyone will look and see. If you're coming in on access, you're agreeing that your results will be public. And then doctors and patients will vote with their feet based off of it. So it'll be a pretty open, transparent thing. The FDA is saying they're going to take 40 that they see as promising based off their criteria, and they'll have total authority on selection. We're not playing any role in that, and they're going to basically give them faster market access.
Yeah, and I've gone through the Tempo application and stuff. It's actually pretty straightforward. So but this is not an R&D program. Your device and your offering should already be already working somewhere, et cetera, and you're just looking for more access to more patients and health systems, et cetera. So with that, any quick questions that have come up? Otherwise I'll continue. Prasad, you have a question? Yeah, go ahead.
Yeah, the first question is that you're talking about the access program for Medicaid. Is it clear that all the any state Medicaid population could be part of access programs?
So access is a Medicare model. I was referencing how states could, in theory, set up their own design to do an access-like program in Medicaid. And so access is an original Medicare program, but we are we literally prepared a payer playbook, which we're giving to payers. We're giving it to the VA. We're giving it to Medicare Advantage plans. We're giving it to states. And we're saying, if you want to converge on this approach for how we pay for digital therapeutics, we would love that. And we're open sourcing everything in how we design this and how it works. So you could set up the exact same thing within your structure. And so the Medicaid conversation was one of the frequently asked questions that we put up on our website at the launch, was around, would states be able to count this towards in lieu of services if they set up a program? And we answered yes. We had a similar FAQ that was designed with Medicare Advantage in mind, which is, if a Medicare Advantage plan pays for this service, does it count as medical expense? And we answered yes. And so we've tried to remove what could be the regulatory barriers towards a Medicare Advantage plan or a Medicaid state program moving to adopt a similar approach.
Are you saying in essence that you need a special request to have Medicaid population as well as FQHC population to be enrolled in the access programs?
No, I'm really saying that in Medicare, it's open for any of these participants to serve folks. In Medicaid, it's something up to the state's control. So that's all I'm saying.
They have no
set that up.
Yeah. But you also pay part of the cost towards the Medicaid. So if the state wants to enroll their Medicaid population access program, are you saying that make a special information, inform them and then see that the Medicaid will contribute their part of it, or what?
It's a great question. At this point, the states actually do not need any special permission, and that's what we put out in this FAQ, was something to give clarity to the states that they don't need special permission from Washington and they're really good to go. So that hopefully will give states the ability to act to set up something like this if it's helpful for them to do so.
Yeah. Yeah, go ahead, Neil.
Yeah, so one comment, one question. The one comment is just an asterisk on the hospitals are doing well. Look at HCAs. You look at a lot of the nonprofits, the market's clearly bifurcated in a big way based on demographics and lots of other things and how they're doing today. And then the second question, which is like a little bit of a DC-ish question. But the reality is this administration tends to do policy a little differently than previous administrations have historically. And I want you to, maybe if you can, comment on the role of Theo and the White House and any policy issues may not be conflicting or interjoining with what you're doing, but the word on the street is the White House plays a much larger role in the policy process than historically it has in past administrations. From a CMS perspective, sorry.
So I'd say that I do stand with my statement on hospital profitability as an industry overall. There's a big divergence if you look at plan and smaller plan performance versus smaller hospital. I'm not saying that there aren't margin pressures on hospitals down the line, but I am saying that the data is true. And I have the data on profitability of a Medicaid encounter versus a Medicare encounter. And there are parts of the country where Medicaid encounters were more profitable for hospitals than Medicare encounters in 23 and 24. The data had just built up in payment shifts that states have driven. And so data's data. You can't argue with it. You could just look at it. Certain segments, certain parts. We have a really collaborative policy process. The reference was to some colleagues at the White House team who work really closely with us. That's very standard for how policy is made. What happens is any part of the government, I work particularly in CMS, we think of ideas and we draft a regulation. The regulation or guidance document that we put together is then through a clearance process where anything from my center goes to the administrator, Administrator Oz, and the other centers all comment on it within CMS. We typically go through 2 or 3 rounds of that before anything makes it out of CMS. After that point, it goes up to the secretary's team. And the secretary's team does typically 2 rounds of review. At that point, we're getting comment from the Office of General Counsel, from the Assistant Secretary for Financial Regulation, from folks with equities across all different parts, the Office of the National Coordinator. What makes it over into the Offices of Management and Budget review is then something that has gone through probably 2 to 5 rounds in total between the 2 or 3 in CMS and then 2 at HHS. It's a really polished document. We then have expert reviewers from the Office of Management and Budget, which are reviewing not just the healthcare documents, but things from across the entire government to then make sure there's synchronous policy across the board. We typically will go through 1 to 2 rounds on major regulations with the Office of Managed Budget, and they'll consult with the policy councils in the White House. That produces a really clear policy which is a statement of administrative priorities and views on the regulations of how we interpret the law. This is exactly how things worked in the first Trump administration, and we follow that same process today. It's been a cohesive process for making sure we're working effectively and working quickly. And I think people see this in the results. We've moved faster than any government I could think of in terms of 9 new major model announcements from the Innovation Center. And just stepping back to look at what that is, that's 2 technology-oriented models, which are really the first time that the Innovation Center has ever done that. 4 models that focus on drug pricing. And if we think about things that are capitalizable in the healthcare system, technology and drugs are the 2 areas that could occur, where we could have massive step forwards in productivity in ways that the healthcare system really has not seen before. And then 3 models that are really focused on accountable care, which do set up the incentive structure for the existing players in the healthcare system to make those investments in those new technologies, to speed the adoptions of things that could enhance productivity. And within that category, we also had a revamped approach to the Healthcare Innovation Awards to look at well-being, functional medicine, lifestyle medicine, and see what it would look like to apply interventions that have data that back them in the Medicare population. So all of these things would not have been possible without a really cohesive and structured policy process at every step of the way, with folks who have expertise and experience in government and the know-how and aligned vision for how we could truly help people live healthier lives so that we can improve quality and lower cost.
Yeah, and for what it's worth, I've spent time in 4 different administrations in the same way that Abe is talking about. The only thing that you're seeing that's slightly different here is that the White House personnel are a little bit more vocal than they have been publicly before. But they are, almost nothing happens at any organizations without it, without that White House.
To the substance abuse, $2 billion of budget cut that was reversed in 48 hours as being an unusual process.
Yeah, that's a conversation. Things don't get reversed without going through. Yeah. Makes sense. All right, question over there. Go ahead and give the mic, Prasad. Thanks.
I'll try to shout.
No, you got it.
Thanks. This has been really interesting. I'm curious if you could share a little bit more about how you prioritize what research and what experiments that you're doing. I think you touched on a little bit with talking about the areas of like potential capitalization, but even within that, there's so many directions you could go, so many different hospitals doing important research. How do you pick which one to focus on?
And is your question anything related to access or generally how they do CMMI research itself?
I think more generally, like how did you get to access and pick the like digital therapeutics like focus?
Good question.
So Medicare, Medicaid, both in scope. In Medicare, around half the lives are original Medicare and half are Medicare Advantage. And then there's a big bucket of drug spend. I came in with a rough idea that 4 years into the term, I'd want to have around a quarter of our work in Medicaid, a quarter in Medicare Advantage, a quarter in original Medicare, and a quarter in the drug space. The portfolio I inherited was actually very well built up in Medicaid. That was a good step that my predecessor had taken, which helped right-size our focus there. It's a lot harder to work in Medicaid, to the conversation that Prasad and I were having earlier. And so that took a lot of work and coordination that was well spent. Medicare Advantage, we were looking at a really empty portfolio, and I have not changed that yet, but I think we should. And then in drugs, we were looking at a single model portfolio. So we announced 4 in that space because of that. We also, there's a couple of different ways that you could cut in each of these. You could cut things by disease state. You could cut things by, is it a hospital, an ambulatory specialty, an independent practice focus model, like the who's the caregiver? You could cut things by, is this something that's going to apply some new lens instead of the traditional caregiver in the healthcare system? Things like the technology models we're speaking about. We tend to do every single one of those cuts and then try and identify segments where if we acted on them, it would move the healthcare system in the direction we want to go. So there's a broad statutory goal, which we stay true to: improve quality, lower cost, and that's our mission. But we want to choose tests that achieve that statutory mission, but also nudge the healthcare system into one that can provide a bit more of a cohesive experience for somebody in it, that could improve access, that could be more affordable, that could really give you better outcomes and change the way you interact with our system. Because too many people fall through the cracks, particularly on the people that we are accountable for in government programs. And so how could we give incentives for the system itself, for others outside of it to come in with access to better serve the folks we're responsible for? There are tons of people in the healthcare system who want to do the right thing, who came in to do this because they were willing to answer the call to be their brother's keeper. Well, hearing that and recognizing that, how do we set up a system that meets them where they are, that nudges them in the direction that they want to go in anyway? And that's our job, to try and identify those experiments by doing the horizontals and verticals and diagonals, or whatever term you want to use for the categories I called out, and then saying, okay, let's pick the things that'll have the maximum impact to move the system. The other thing I just want to say is, I don't really care as much on the scale achieved in the experiment test. Access is a 10-year model, so that's a long period, largely driven by the sample size we thought we need to get enough data to have confidence in certification, because you really need to know it works to make it work. I care more on the scale and impact it could have on people when certified and proven to work. So we need a certain scale to draw a valid conclusion, but assuming we're able to draw the conclusion, the real ideal is getting to the scale at which it's impacting the whole system, and it's something people could rely on in perpetuity.
And for what it's worth, the input towards the actual research itself can come from practitioners, from community. In fact, they appreciate it, because I've actually given ideas and actually been brought in to, hey, tell us more about your idea, et cetera, et cetera. No special knowledge or anything. It was just like, hey, I've got these 10 things that I'd like for you guys to try. They said 9 of them are crazy. We're not going to do them, but one of these sounds interesting and we'll look into it, right? So that's actually a very good way to think about it and go forward. Is there anything else you wanted to add? There's another question over here. Right behind you, Prasad.
Thank you so much for being here. I work in biotech development. And one thing that I see, specifically in oncology, and one thing that I see in our healthcare ecosystem is just there's so much waste, right? So in terms of how other countries manage their oncology patients, they have well-being frameworks. And I believe there's an OECD, and there's a list of all these countries that are more proactive in terms of human well-being. And they have an infrastructure, probably because they have socialized healthcare systems. So what has CMS done to kind of think about in a different way, a more proactive, to have an actual well-being infrastructure, because we're kind of a very reactive system?
It's a great question. What does it look like to get to a healthcare system where someone is proactively looking out for your long-term outcomes, where is going to engage and think ahead and look around the corner on your behalf? Because it's hard to do that. I'm sure we all have navigated the system ourselves, or have loved ones that we have helped through that process. And how can you make that easy? How can you make sure there is access, but also that there's not the burden of outreach falling on people in moments of vulnerability? Because when you truly need to interact at the healthcare system, you are likely at your most vulnerable and you're lost. And this isn't an everyday thing. And I think some of us in this room, all of whom would say, we're healthcare folks to some extent, whether you're tech healthcare folks or healthcare folks, you're in this room because you're a healthcare person, and you probably have felt lost when engaging with the healthcare system. So that's not a sustainable answer. We need a better answer. We made prevention one of the 3 pillars of the Innovation Center strategy early last year. Our strategy stands on evidence-based prevention and ensuring uptake on that. It's about empowering people to achieve their health goals, giving them choices, but really about trying to intervene earlier. I do think the accountable care framework that we have tried to encourages that and enables that. Because rather than waiting for the patient to crash in and need to show up for the dialysis appointment without having known they have kidney disease, or rather than waiting for the patient to show up in the emergency department, you actually want to engage with them and catch the thing earlier. And as the cost of running scans falls, because technology, due to people like you, makes things more efficient, as the cost of engaging in with somebody to help them achieve their healthcare outcomes falls because you don't need as much really expensive human labor involved in the care delivery. You have a lot more upfront design work involved. The ability that we'll have to engage people is increasing. We just need to give an incentive to do so, a way to pay for it so that folks in the community are enabled to do that. And so we're working on that. And I do think the lead model is a big step on that. And like, I believe in that. I think access is a step in that because it enables folks outside the healthcare system to do it with limits, because I don't think tech is the answer for every healthcare need. And I don't want to end up in that scenario. We are also trying to encourage investment in certain areas in biotech to make things more achievable. And we have put lifestyle at the heart of our approach here. So Balance, which is the model that gets a GLP-1 coverage to give folks on Medicare or Medicaid access to GLP-1s for $245 a month. That's the plan and the individual cost, $50 copay. It's called Balance because there are lifestyle offerings available to every person who's getting access to GLP-1 in that model. And that was important to us.
And have you considered some sort of a financial incentive for organizations, kind of similar to like the environmental models, whereby, you know, if you make your home more energy efficient, you get a tax incentive. But then if, you know, Ford reduces their environmental carbon footprint by X number of years, they get a tax incentive. Is there anything like that that CMS is kind of looking at in terms of healthcare for prevention? Kind of like a financial incentive if they have a well-being framework and they have X number of reduced claims by X number of years in diabetes and obesity and blood pressure. Like, have you ever considered anything like that?
I think we have some frameworks like that, not through the tax code, though. The tax code is administered by the Office of Tax Policy and the IRS over in Treasury, so I can't directly influence that. And Congress tends to say how that works. But what we can do with our authority is say, let's look at the patients attributable to your system. So these 10,000 patients all engage with you. All right. And let's say, here's what we expect both the cost of care profile to look like, and also where we expect you to be on outcomes, and we can pick which outcomes they are. And we're trying to be more less process and more true outcome in how we think about quality within our models. I'll call out the Chief Medical Officer of the Innovation Center, Dr. Susanna Bernheim, who's done an incredible job. She's a quality expert that came to us from Yale, where she had run a whole organization thinking through quality measurement and how to approach it. And she's leading our push for what does it look like to say, let's actually measure A1C levels here. Okay. It's something that we have to have a way to report. So what does it look like to collect that data? And is there a way that that could be done as a requirement of being in the model? And do we think that we could access information from EHRs in a meaningful way that's doable? Like, there's a bunch of hurdles to get at, like, can we collect this usable data? So let's say we overcame that. In access, we did. A1C is one of the metrics for the early cardiac metabolic health track. And then it's like, okay, you have to achieve that measure in order to get back your payment from the quality bonus pool that's included in it, in order to get your outcome aligned measurement. So where you're going is exactly where we're trying to go in the system and what we're trying to set up. But I'll confess, it's not through the tax code, just because I don't control that.
Yeah, and so we've got a few more minutes. So what I'll do is, you mentioned that you're not that concerned about which specific technology gets selected, which is great because you and I don't know what's happening next year. Perfect. However, given the speed of AI,
welcome tips though.
Yeah, we'll take the tips. That's right. But given the speed at AI, obviously the government itself is trying to embed more and more AI. What is your, either it could be your personal opinion or it could be CMS's opinion around human intervention in AI being required, or are you allowing or encouraging AI to be more autonomous? Anything that you can give to this group, because this is what we work on a daily basis, would be good.
It's something we've put a lot of thought into. I don't think we have a definitive answer on this. Like, one idea that was pitched was you should take the entire fee schedule and give the ability for AI to do it without humans involved, as long as the company attests that they could do it safely, or maybe you require the FDA to do it, different versions of this pitch, and pay us 5% of the fee schedule for it if we could do it entirely with AI. All right. we didn't take that approach, to be very clear. But it would have been very different than what Access set up. It would have been a broad-based thing. And I don't know, maybe it would have worked. Yeah. I want to see how this plays out. I think we put out guardrails where we're not prospectively saying how things work. There is an interest in saying that, like, some of these things should come and be able to work. I mean, you're not allowed to bill fee for service something that AI is doing on its own. So there's not a way to do that.
So, but pause for a second. Let's repeat that just so everybody understands that the AI part of it can do the work, but you can't charge for it. So you want to just kind of repeat that and make sure everybody gets that.
Free. Yeah. The freemium economy. But you can't bill fee for service for the AI doing the work. But if you have a value-based care arrangement and you know your attributions, you know the patients are in your system, and your system believes, hey, this really works for our patients, we can engage and help people stay healthier with fewer actual interventions by human clinicians, systems are going to adopt this. So that's what we tried to set up. The statement of the tech vendor on their own, a very limited thing where you get a limited payment on these tracks for chronic care management. But the people we trust as gatekeepers to make the determination of what will work for the patients they care for are really health systems and physician groups, where we're really outsourcing the job of making that judgment to them. And we're going to measure them all on quality. So they all know that. You know that. But you could think through what makes sense to adopt, and you could experiment and have this time period to see what really works for you, while locking in your revenue line via value-based care arrangement. And so my answer is not that Washington should essentially determine how this works and should try and police it, but rather that I should give clear incentives that you have to have quality adherence and you have to meet this. And systems are very sophisticated at managing that, at avoiding risk and all that, while giving a clear upside and win for moving in that direction. And so that's how I've thought about it. It's very different than the modifier on the fee schedule. It's very different than saying we should have new technology add-on payments. And it's also very different than saying we should have specific CPT codes for AI, all of which are ideas that are out there. And we didn't do any of those.
Yeah. And so this last question, and you've been very, very generous with your time, so we appreciate that. So as you think about your trajectory, where you see CMS heading in general, because you're helping innovate there, what would you give tips and tricks to in terms of the CMIOs, CEOs, CFOs about how should they start thinking so that they align with your thinking if they happen to be taking a lot of Medicare fee-for-service today? And
I'll note that we have tried to open up in the new lead model a pathway where states can assign Medicaid risk in the same way to ACO entities. And so we open that up. We're looking for states to work with us. I'd love to have 2 states come in and say, hey, in our state, let's assign Medicaid risk to the ACOs as well. I note that aligns with some of the changes we made in AHEAD, which was a pre-existing model we inherited that we made tweaks to make it look a lot more like an ACO type structure, where again, there's Medicare and Medicaid risk, and there at least one commercial plan assigning risk in each of those states. And so there's a convergence here of we want to capture a larger share of mind share, not only on Medicare, but also on Medicaid and even the commercial book of business by converging on how we approach this. What I would be saying, though, is that the strategic direction for hospitals at a moment where, for many bigger systems, stable, but everyone's looking out ahead at changes that will phase in over the years ahead. What you want to do is be thinking about that, preparing for that, and investing so that you could be in a position to continue to serve the communities and offer them more in the years ahead. And you really need technology at the table, thinking through where there's operational efficiencies, the ops team thinking through how that would flow through in incentives for the member of the clinical team that are in there, the team that are experts on the different clinical interventions that would be driven proactively for patients, the population health management team that would be responsible for deploying that, and finance buying in and seeing this and seeing that this could work by shifting the entire system to accountable care. I've spent years working on this. There are many people here I know who have touched on accountable care in addition to touching on health tech. I think this is the way to get there. I think this is the way to encourage the adoption, set the right incentives, and have local communities empowered to make these decisions on their own instead of that being a centrally defined thing in Washington. And I think that's valuable. So my pitch is to have all these different functions of a system working together, buying in and moving the ship. And we're giving a 10-year runway for that reorientation to happen.
Well, that was great input. Big round of applause for Abe here.